Good afternoon. My name is Carol Kramer Brooks. On behalf of the Office of Juvenile Justice and Delinquency Prevention and the National Center for Youth in Custody, I am pleased to welcome you to today's webinar, Access to Healthcare for Vulnerable Populations, part of our series on improving conditions of confinement for youth in custody. We hope that you have found this series informative. The NCYC is committed to providing quality training opportunities for the youth in custody field, and today's webinar is no exception. The panelists are two of the best in the business. So without any delay, I will turn it over to our moderator for today's webinar, the newest member of the NCYC team, Ms. Natasha Martinez.
Thank you, Carol. Good afternoon and welcome to everyone to the National Center for Youth in Custody's webinar series on improving conditions of confinement for youth in custody. Our webinar today is titled Access to Healthcare for Vulnerable Populations. My name is Natasha Martinez and I am a Program Associate for the National Center for Youth in Custody, or NCYC. NCYC is a National Training and Technical Assistance Center created by the Office of Juvenile Justice and Delinquency Prevention and coordinated by the National Partnership for Juvenile Services. The National Institute of Corrections also serves as a partner with the center. We are very pleased to have you with us for what promises to be an excellent and informative presentation. This webinar is the third and final in our series of webinars focused specifically on improving conditions of confinement for vulnerable youth. Before we begin, I'd like to address two housekeeping matters. First, this webinar is meant to be interactive, and we encourage everyone to submit questions through the chat function on your screen. In between the panelists' presentation and also following it, we will have two question and answer periods, during which time we'll address as many of your questions as possible. You may submit questions at any time throughout the webinar. Second, at the conclusion of the webinar, we would appreciate if you would complete a survey on the presentation. The survey will pop up automatically when you exit the program. Having your feedback is vitally important to us as we plan for future webinars and training. So before we begin the webinar, Callie from the National Training and Technical Assistance Center will go over some technical aspects of today's presentation.
Thanks so much, Natasha. Good afternoon, everyone. My name is Callie Long Murray, and I am with OJJDP's National Training and Technical Assistance Center. I would like to take a couple of minutes to discuss a few features of Adobe Connect, which will help you maximize your opportunity to participate in today's webinar. To view the bios and photos of the presentation panel, please access the documents which are available now in the handouts pod of the webinar dashboard. Numerous handouts will be referenced today that are located there for your resource library. To send a chat message to me, your host, a panelist, or another attendee, click the menu icon in the upper right corner of the chat pod. Choose Start Chat With, then select Hosts, Presenters, or Specific Attendees. Type your message into the text box and then hit Enter or click the message bubble icon to send. For those of you participating in today's webinar as a group, please take a minute and help us count. Go to the chat window and type in the name of the person registered and the total number of additional people in the room with you today. This will help us with our final count. Again, if you are viewing with a larger group, please type in the name of the person registered and the number of additional people joining you today. This event will be archived in OJJDP's online university at www.ntac.org in approximately 2 weeks. You can also check out past webinars by NCYC that have been archived on the online university. They have presented some great information that we are happy to share with you, so please access these important resources at your convenience. Again, thank you for joining us today.
Thank you, Callie. Let us begin. As many of you know, with increasing frequency, youth with significant and sometimes highly specialized healthcare needs, such as pregnancy, adolescent HIV and AIDS, diabetes, and others, are placed in confinement facilities. Facilities charged with the care of these youth need to have processes in place to identify healthcare needs and access to the resources required to effectively address these needs. Additionally, facility staff must have a clear understanding of the federal requirements under HIPAA to protect the confidentiality of youth's medical information, including diagnoses. This webinar focuses on identifying symptoms related to specific health needs of youth in confinement facilities and the appropriate policy and staff level response to the needs of these youth. Specifically, we will be focusing on understanding the healthcare needs of residents presenting with adolescent HIV and AIDS, sexually transmitted infections, and pregnancy, discussing appropriate and inappropriate strategies for restraining pregnant residents, understanding the steps to implement responsive dental services, increasing knowledge of federal HIPAA requirements and the impact of these requirements on staff's right to know. We're going to open the webinar by giving everyone the opportunity to hear from Dr. Ezike and Michelle Staples Horne. Dr. Ngozi Ezike is the Medical Director for Kermack Health Services at Juvenile Temporary Detention Center of Cook County, located in Chicago, Illinois. JTDC is the largest single-site juvenile detention facility in the country with an operational capacity of nearly 400 residents. As a board-certified internist and pediatrician, Dr. Ezike also serves as an attending physician on the patients unit of John H. Stroger Hospital, formerly known as Cook County Hospital. Active in developing the next generation of medical leaders, she serves as a preceptor and supervisory attending for medical interns and residents, as well as nurse practitioner and physician's assistant students. Dr. Ezike completed a combined residency program in internal medicine and pediatrics at Rush Medical Center in Chicago after graduating from University of California, San Diego School of Medicine. Her undergraduate chemistry degree is from Harvard University. Dr. Ezike has conducted poster presentations, facilitated roundtable discussions, and delivered workshops at NCCHC national conferences on topics related to juvenile correctional health care. Dr. Michelle Staples Horne has been Medical Director for the Georgia Department of Juvenile Justice for 20 years and is responsible for the clinical supervision of medical services to youth served by the department in 27 facilities across the state. She received her medical degree from the Morehouse School of Medicine and her Master of Public Health in Health Policy and Management from Emory University in Atlanta. She holds both a Bachelor of Science degree and a Master of Science degree in Biology from Clark Atlanta University with research experience in biochemistry and microbiology. Her clinical experience includes pediatrics at Columbia University's Baby Hospital in New York and preventive medicine at Morehouse School of Medicine. Dr. Staples Horne serves on the Juvenile and Health Care Committees of the American Correctional Association, the Juvenile Health Committee of the National Commission on Correctional Health, and is past president of the Society of Correctional Physicians. She is also a part-time adolescent health provider for a local public health clinic. Dr. Staples Horne has conducted training, consultation, and contributed several articles and book chapters on correctional health care. As you can see, these ladies are more than qualified, and we welcome their presentation today.
Dr. Staples Horne, if you want to go ahead and unmute yourself and begin your presentation, that would be great. Thank you.
Good afternoon, everyone. This is Dr. Staples Horne. Can you hear me okay now? Thank you. I'd like to begin with the communicable diseases because this is one of the primary healthcare concerns in correctional settings. We really need to identify and control these communicable diseases so that they not spread within the facility. There are national recommendations that exist for medical intake screenings and assessments. These guidelines should be followed, and we should be able to make certain that medical staff are available to conduct those assessments. But if they're not available, non-medical staff can be trained by them to conduct these screenings prior to the youth being placed in general population. There is, of course, a high risk of exposure to respiratory illnesses such as tuberculosis, influenza, and even the common cold due to such close confinement. And also, skin and contact diseases can be easily spread in such an environment
such as common lice and methicillin-resistant Staphylococcus aureus, Staph aureus, or MRSA, which is much easier to say. Sexually transmitted infections, or STIs, are also quite common in the adolescent and young adult population. Adolescent females up to age 26 should all be screened, since this infection is often asymptomatic and can lead to sterility problems and other concerns for the young lady down the road. It's also appropriate to attempt to really eliminate HPV and hepatitis B and A from this population, because we do have vaccines that are available to us through the Vaccines for Children's program, and this is a federal program where we can provide free vaccines to individuals within our population. Dr. Ezike will cover HIV in detail when we get to that section, but we really would like to point out that youth simply are not smaller adults, that we have to create specific services that are important for identifying them early in their HIV infection, and also have a robust program in place to identify them and provide comprehensive services. We also want to make certain that we have great continuity of care while they're with us, and certainly when they move to the outside. And by addressing psychosocial issues, those are important as well, because these young people have certain social, medical issues, psychological systems that impact their care when we provide primary care for these youth.
Thank you. This is Dr. Ezike. So hopefully everyone is aware that there's a global HIV epidemic. This epidemic has not spared the youth. 50% of all new infections globally occur in adolescents and youth, with the age range being defined as age 15 to 24. In the United States, for example, in 2011, over 2,000 teenagers were diagnosed with HIV infection. This is a big shift from the 90s, when children were diagnosed with HIV/AIDS, most likely contracted from the womb from an infected mother or during the birthing process. Another way that it was contracted earlier on, before the HIV screening began, was through blood transfusions. Please note that now the risk of a blood donation carrying HIV and transmitting it to a patient is 1 in 2 million. Extremely, extremely low. So now adolescents are primarily acquiring HIV infection from sexual activity. There is also a smaller percentage of adolescents who are contracting HIV from needle use, whether it's intravenous drug use or from tattooing, which is a very common practice in our society today. In looking at the epidemiology numbers, I may have to go back and forth a little, bear with me. You will see that there are differences in terms of the rates of infection across different states and regions of the United States. The South has higher rates than the rest of the country, as does Illinois, Michigan, New York, and New Jersey. So armed with the information that adolescents have a significant risk of contracting HIV, which of course is a lifelong chronic disease, we in corrections have a significant role that we can play. Pardon me. Pardon me, I'm missing the slide on risk assessment. Here it is, I apologize. So first is risk assessment. We have to ask the hard, personal, difficult questions to determine youth practices. Are you sexually active? Do you have multiple partners? Do you use condoms? Do you use intravenous drugs? Do you have tattoos? Were the needles used in the tattooing sterile? Although risk assessment is very important, we still need to screen our youth in order to definitively know if they have the infection or not. And again, depending on the area of the country in which you live, the American Academy of Pediatrics has different recommendations as to what screening tools should be employed. For instance, if you're in a low prevalence community, it's still recommended to offer HIV testing to all adolescents who report sexual activity. If you're in a high-risk area, it is recommended that you offer HIV screening to all adolescents, for sure by the ages of 16 to 18. If you're dealing with a high-risk youth, a youth who has identified several high-risk factors, then annual testing is recommended. And the CDC concurs with the AAP. In fact, the AAP is following the CDC guidelines, and the CDC recommends testing for all people from 13 to 64. Again, things vary by state, but in many states, adolescents can consent to HIV testing without parental consent. So again, please check with your local laws and regulations. Regarding HIPAA and confidentiality, and we will get into more detail, there are specific federal laws concerning the privacy and confidentiality of HIV/AIDS diagnoses. Direct care correctional staff may not in fact be aware of individual use diagnoses, but all direct care correctional staff are strongly urged, just as are the medical staff, to use universal precautions in all situations. Regarding treatment services, the first step, of course, is to identify who is the HIV positive youth. And once the youth is identified, comprehensive youth-centered practices are needed. Just as Dr. Staples Horne referenced early, it takes a youth-centered approach to make sure you deal with the issues unique to young people. The team in such an instance would involve a primary care physician, an HIV specialist if the primary care physician is not well versed in HIV care, mental health specialists, psychologists, psychiatrists, social workers, and potentially a pharmacist if complicated medical management is necessary. Medications may or may not be indicated based on a number of different factors, including medical factors and social factors. A very critical piece is the follow-up. This is a chronic disease, of course, and the linkage to providers in the community is critical so that care can be continued after release. And even for youth not started immediately on medications, regular follow-up would still be necessary to determine if and when medications would eventually be needed. And of course, education, education, education. Staff working with HIV-afflicted youth and all youth in the facilities should be armed with the facts of HIV/AIDS, and the myths should be dispelled. So again, just to recap the goals regarding HIV/AIDS, we want all kids to be educated on HIV/AIDS and all the STIs to prevent or minimize infection. We want testing to identify those people, And we want the appropriate care, the comprehensive youth-centered care, to be given to those kids that need it. And of course, we need the transition into outside care in the community for after release. And for kids who are coming in already with the diagnosis, we need to continue the care in-house for those kids who have already been started on a certain regimen.
So what are the challenges in providing HIV care for youth that are detained? The first thing being the term of detention. Oftentimes it is a short period, and this has implications for medication therapy and certainly would require additional follow-up and continuity of care. Although parental notification is required, although youth have to actually allow the parents to access their HIV information just as other STI information, it's important to encourage youth to share that information with the parent. You yourself cannot do it without their authorization, but it's important for them to share with the parent because those parents can provide emotional support and also help navigate the healthcare system for treatment and care of that young person when they're out in the community. Post-incarceration continuity of care is really critical because we have to link with those community providers, and even if that young person returns to the facility, we need to connect back with them so that that medication regime will not be interrupted and the best medical outcome occurs for that young person. With regards to confidentiality, that should be maintained really following all of the HIPAA guidelines, and we're going to cover that in detail at this point. HIPAA is an acronym or stands for Health Insurance Portability and Accountability Act of 1996, and it is a federal law about the privacy, confidentiality, and electronic security of protected health information. HIPAA really has two parts. It has the privacy rule, which applies to this protected health information in any form, whether it's verbal, written on a regular chart, or sitting there for anyone to access. And the second part is the security rule, which really covers the protected health information that is electronically stored or transmitted. Therefore, if you are sending medical records or health information through an electronic device, computer, or even a fax machine, you have to have certain rules to make certain that that information is protected, such as encryption in the computer system, so that persons that are unauthorized to access that information would not be able to see it. The access to confidential information must be limited to persons and public agencies with both a need to know and a right to know. Need to know would include certainly healthcare staff, and certainly in some instances, for example, a probation officer may need to know that a youth needs to get to an appointment, but they may not necessarily need to know the details for which that young person is going. Another very common security example would be a youth with a seizure disorder that may have the seizure disorder, but the security staff need to know not to place that young person on an upper bunk in case of a seizure. And of course, a right to know. Staff should be provided with information required for the performance of their duties. So someone, the medical director or someone in the agency and via policies and procedures needs to determine which staff need to be provided with that information and how it's transmitted.
Again, as Dr. Staples Horne mentioned, protected health information can be in a variety of forms, whether it's via fax, email, even spoken. So all of these modes of delivery of information must be safeguarded. So it's very important to remember the verbal, how the spoken word can result in transmission of protected health information. An innocent conversation at a lunch table or in an elevator could be a violation of HIPAA. So any information that is inadvertently overheard must also be kept confidential. For example, if someone hears something as a transportation worker taking a child to an outside appointment, the fact that they overheard some information does not now give that person the right to share that information. Again, any information inadvertently overheard must also be kept confidential. And compliance with all HIPAA privacy and security rules is required even off the job. So even after going home or on vacation, that information is still protected and compliance must be maintained. So here is a simple, rather straightforward example of medical information that would need to be shared with correctional staff, whether it's the direct care staff or the dietary staff. It would become very clear why we would want the staff to know of, for instance, a child's food allergy. The food that could potentially cause a life-threatening reaction should be kept away, obviously, from the patient in order to prevent this life-threatening illness. Some of you have seen how intense a severe food allergy can be. You know, an itchy rash can progress quickly to throat swelling, difficulty breathing, and even worse. So everyone involved with the youth needs to play an active and actually proactive role in ensuring that the wrong foods are not served to the child. Additionally, armed with the information of a food allergy, should there be an unfortunate exposure, prompt recognition to alert medical staff or to administer the EpiPen could result in saving someone's life.
Wonderful. Thank you, ladies. So far, we're going to take a short break just to answer a couple of the questions that have come up thus far in the presentation. First of all, we had a question regarding the map that you had put up with the rates of diagnosis of HIV. Are the higher rates of diagnosis a result of a better effort at testing centers in those states over other states? And if not, what do we know about why the rates of diagnosis in those states are higher?
I think there are many potential answers to the question. First of all, we can say that there are different rates of testing in different areas. So the graph put out by the CDC cannot discriminate what percentage of the adolescents have been tested in that region. So even a state with a higher rate, it doesn't necessarily mean that they had higher testing rates than a state with lower. But obviously, to get any kind of a positive percentage, there would have to be some testing. There are multiple reasons. There's some sexual literacy, just education about ways to prevent pregnancy or to engage in safe practices. It could be that there are some areas with lower sexual literacy in young people. There could be areas where there is less access to methods to prevent sexually transmitted infection. Those are two plausible, possible explanations for higher rates in certain areas.
Thank you, Dr. Ezike. And what was the meaning of the states colored in white? Did they just not have reporting information?
Yeah, I think there's some places with no numbers reported, and I'm not clear why it's not reported, especially for, I'm trying to find it. Like I said, I think it was California was one such state. So for some reason, there was no reported information. Of course, I know there is some testing going on in some of those states, but I guess it wasn't able to be collected into the format to be recorded into this CDC statistic.
Thank you. And HIV status is protected, correct? So what about disclosing to non-medical direct service staff? Do you disclose to them as well, or rely on universal precautions?
So that's a very good question, and it's one that always comes up when I orient new staff. The way I usually answer that, there is a federal law that prohibits, specifically for the diagnosis of HIV/AIDS, prohibits the disclosure of an HIV/AIDS diagnosis, and it comes with stiff federal penalties up to and including $250,000 fine, 10 years in prison. So it's a special law that is specific only to this disease. I usually tell the staff, we really don't know the HIV status of many people. We don't know the HIV status of our coworkers. Some people don't know their own personal HIV status. We don't know the HIV status of kids who haven't been tested. So in the safety of, in the safety for everyone, we have to assume that everyone is positive and use universal precautions in all instances where bodily fluids could potentially be exchanged.
So then is that how you typically respond to correction staff who feel that they have a right to know for personal security purposes as well?
Yeah, that's exactly what I say in the orientation.
Great. And can you say anything about how the need to know criteria has been interpreted in the mental health domain? Did you hear that question, Dr. Ezike?
This is Dr. Staples Horne. Dr. Ezike may be having problems with her audio portion. Basically, with your question, I'm sorry, Dr. Ezike, are you back?
Sorry, I just lost network connectivity. I think I'm back now. Sorry.
Sorry.
I don't know what the question was. There was a final question.
Yes, there was a question asking how the need to know criterion had been interpreted in the mental health domain. Dr. Staples Horne, if you want to go ahead and jump in on that one.
Yes, I will. And is this with regards to HIV status as well, I suppose? Basically, it goes back to the need to know, and if there is a clinician, for example, because oftentimes youth that have been given a diagnosis of HIV or AIDS need the mental health support, and so those particular individuals are clinicians, just as the medical staff are clinicians, and that information is critical to as they develop their treatment plan.
Thank you. And do you have a suggestion as to how often youth should be tested while they're incarcerated?
Certainly an initial assessment, and what we generally do is we always ask or conduct a risk assessment to see if they are at risk for HIV, and then if you have resources, ideally you should do opt-out testing, which CDC recommends, such as getting the HIV testing done as a routine part of the intake process. And then if you don't have the resources for that, then certainly utilizing a risk assessment instrument to determine which youth should be offered HIV testing, and also for those specific populations like pregnant females, those youth that have been exploited in the commercial sex industry, that should also get HIV testing. And then depending on when they come and go, you can repeat the testing in 3 to 6 months, depending on whether or not they've still been in the facility or been out to get an additional exposure.
Dr. Staples Horne, a question for you on training. What training do you provide to facility staff regarding communicable diseases, health issues, things like that?
Yes, we include that in our basic training for our correctional officers on communicable diseases. We also include a HIPAA training for all staff in DJJ, not only the medical staff, and this is a requirement prior to them having access to our computerized juvenile tracking system. I think it's very important that all staff are aware of the risk of sharing protected health information, and that they're informed as to their risk and the needs of the youth with regards to preventing the spread of communicable diseases, not only within the facility but outside to their family as well.
Great, and a question for either of you. Is it accurate to say that HIV is contracted more often during incarceration?
I would have to say I hope not. I don't think HIV is contracted during incarceration. It might be for youth that have never been tested before. The offering of the testing in incarceration might give them the opportunity to detect something that they otherwise wouldn't have been detected if they hadn't presented themselves to a clinic for testing. So they're not contracting it while incarceration, but it might be detected during that period.
Great, and sort of a follow-up to that question, can you speak at all to the needs of the LGBTQ youth in state custody? Because given that this community is disproportionately affected by STIs, HIV, unintended pregnancies, sexually violent activities, etc., do you have specific training tools you utilize and recommend to other agency officials for this particular community?
I can address that. We actually, because, and I was going to address it in the next segment under pregnancy, but PREA, the Prison Rape Elimination Act, does require screening components for assessments and youth that gay, lesbian, transgender, or questioning, that we do make accommodations for those individuals and that staff are trained in providing care to those individuals and they are not discriminated against. So that is a component of our training, really will be a component of everyone's training, as we all have to meet the PREA requirements. I want to also make a quick comment about the HIV and contracting HIV in the correctional setting. It takes two pieces for that to occur. First of all, you need to have a prevalence or have infected individuals in that environment, and you have to have sexual contact between those individuals that are in that correctional setting. So I think in comparison to an adult population, I think in general there is less sexual contact among juveniles than in some adult systems possibly. And certainly we believe that there may be more HIV-infected adults incarcerated as opposed to individuals, but no one really has hard stats available on the true prevalence of HIV among adolescents that are being detained or incarcerated.
Wonderful. Well, we're excited to hear the rest of your presentation, so we're going to save the rest of these questions for after and go ahead and let you both proceed.
Okay, I will pick back up with one of the other objectives, which is pregnancy, and how critical that is to make certain that you do not have a young lady that's pregnant in your facility and you're unaware of it. Therefore, screening needs to occur on all females, regardless of the sexual history that they give, and urine pregnancy tests are the simplest way to do this. I had mentioned earlier regarding PREA and the Prison Rape Elimination Act requirements, which really requires not only an assessment for abuse, but also follow-up for any history of any sexual assault that may have occurred within the facility or even in the community. So certainly there has been a sexual act if you have a pregnant young lady, so additional questioning needs to occur to determine whether or not that pregnancy was the result of a sexual assault or not, and even whether that pregnancy occurred from an older adult male, because that, again, depending on which state you're in, will bump that up to the child welfare reporting requirement. We are mandatory reporters, most clinical staff in most states. You may, however, have policy differences within your facility that mandate that the healthcare workers report to a administrator, director, commissioner, or whomever that would then make the report to the child welfare agency. As far as clinical assessments and referrals, if a young lady is pregnant and confined to a facility, you must have that connection to an obstetrician, either off-site care that the young lady is taken to that specialist, or in cases where you have a larger facility or maybe more pregnant females, you may want to contract or arrange for an OB to come on campus and treat the young lady. Ideally, you would want to be able to link the young lady with the obstetrician that was caring for her in the community, so that care may be able to continue during the period of detention. Special diets may be required. In general, an extra serving of milk is about all that's required, since in most juvenile settings the diets are very good. But in order to make certain that you are providing what's needed for the pregnancy, I would recommend that you have that diet reviewed by a registered dietitian. Activity restrictions may be required in certain cases, although pregnancy in itself is not a reason to totally restrict any physical activity. But if those restrictions are made by medical staff, then the other correctional staff need to be aware of those. Security restraints. This is a huge one, and this is one of the topics that I think people are most interested in. There is a position paper that was done by the National Commission on Correctional Health Care regarding the restraints of pregnant inmates, and that full position paper can be found on their website at ncych.org. I'm going to just quickly try to run through some of the recommendations. For prepartum or before delivery, restraints should be done in the least restrictive means necessary and a way that really does not create any adverse clinical consequence for the young lady. Abdominal restraints that directly constrict the area of pregnancy should never be used. Wrist restraints, if used, should be applied in such a way that the pregnant inmate may be able to protect herself and the fetus in the event of a forward fall. Pregnant females should not be placed in a face-down position or in four-point restraints. Leg and ankle restraints that restrain the legs close together should not be used because they increase the risk of a forward fall. And then definitely during transport to the hospital or during active labor, restraints should not be used except when it's really a serious threat to harm or self-harm. And I think that decision needs to be made by a medical provider and not by security in isolation. Restraints are best to be avoided during labor and delivery, and also even after the baby is born, because of the possibility of being able to address medical complications such as hemorrhaging, allowing the bonding period to occur between the mother and the baby. It's important in that whole scenario to make certain that you have, in advance of the actual delivery, that you have made certain arrangements for the hospital and any aftercare planning, and that everyone is included in that pregnancy plan. And finally, I'd like to say a word about prevention and prevention of pregnancy, because we know that early pregnancies have negative outcomes with regards to the young lady's ability to complete her education, and also increasing the risk of her remaining in poverty. So we want to certainly prevent any repeat pregnancy by informing the girls of any birth control options, everything from abstinence to long-acting contraceptives such as implants and IUDs, and let them know where they can obtain those devices. And certainly if they are not pregnant, we want to prevent that pregnancy as well. I'm going to cover medical conditions next that really have implications in our correctional environment. Dr. Ezike will cover diabetes specifically, but I'll just try to hit very briefly on some of these other conditions. Hypertension is more common in adolescents, primarily now relating to obesity, poor diets, and low activity levels in the community. And it's important that we teach self-management for these young people so that they will have a better outcome when they are released, and better self-management, and hopefully these will not result in uncontrolled hypertension leading to kidney failure, blindness, and some of the other negative outcomes. Immune deficiencies are rare, but if you have a kid that does have an immune deficiency in the facility, then remember that he really needs to be protected as well from the various infectious sources that are within the facility. Orthopedic conditions and injuries are quite common in this population and often require special devices such as braces or crutches or things that really make the hair stand on the security staff's head. So we really have to have conversations and require communication between medical and security staff to really coordinate and create a balance between the medical needs of the youth and those security risks. We mentioned earlier with regards to food allergies, and in addition to obtaining the histories from the young people and really trying to determine whether or not they have a true food allergy or have a food preference, it's important to try to get some type of confirmation of the allergy, hopefully from a parent, etc., get a detailed history, but also a simple blood test can be used to really confirm the presence of that allergy. And of course, the EpiPens, as Dr. DK mentioned, really need to make sure that those are accessible. Asthma and respiratory conditions can worsen with environmental triggers that really may require special management, including ready access to those meter-dose inhalers and a special plan with regards to their use. And really all youth with special medical needs require a treatment plan that meets their medical needs within the setting of a secure environment.
Moving on to diabetes, let me start off with the classification because it's a big question that I often get. Why do some people need insulin and some people do not? Well, this is a rather simple explanation, but there are two types of diabetes, type 1 diabetes and type 2 diabetes. Type 2 diabetes is the one that we used to think of as an older adult disease, and type 1 used to be known as juvenile diabetes because that was the type of diabetes that you usually acquired in childhood or adolescence because your body, particularly the pancreas, did not produce insulin. So therefore, you needed insulin to replace the insulin that your body was not making. But in type 2 diabetes, your body does have insulin, but sometimes, whether it's due to obesity or some other issues, your body couldn't use the insulin properly. So seeing adolescents with type 2 diabetes is a newer phenomenon that is related to the obesity epidemic. With increasing obesity rates, more adolescents are being diagnosed with type 2 diabetes. Therefore, screening should occur in youth with recognized risk factors. Some of those risk factors include, as we said, obesity, so you can calculate the body mass index or BMI just using the height and weight. Family history, there is a role for heredity in both type 1 and type 2 diabetes, so family history of diabetes, and certain ethnic groups have increased rates of diabetes, namely African Americans, Native Americans, Hispanic Americans, Pacific Islander Americans, and Asian Americans. Another one that's important to note is just low activity level. Again, that would predispose one to obesity, but even that on its own is a risk factor. So again, patient education is such a key thing in all chronic illnesses. Youth need to understand what diabetes is and what they can do to control this lifelong illness and curb the long-term side effects. In the same vein, we've already talked about patient education. Self-management is a very important part of diabetes. The doctor can only do so much. They might see the patient once a month, once every 3 months. It's the youth that has to be empowered to deal with the illness, and that will involve testing oneself, taking one's medications, etc. Lifestyle modifications can be a treatment in itself. Staying active is very important, making the necessary dietary changes, understanding the relationship between the foods eaten and levels of sugar, and then of course, follow up and monitoring the long-term sequelae. We need to understand that there are long-term effects of diabetes to many different parts of the body. With regular follow-up to keep watching out for these consequences, we can hopefully minimize or delay future complications. This would involve annual eye exams to help prevent and stave off retinopathy. There are, regular blood tests to see how the diabetes is being controlled or potentially not controlled. So again, the treatment options, lifestyle modifications is a mainstay in the list of options. In some diabetics, just controlling what's eaten, what's ingested, and the amount of physical activity, upping the physical activity, that alone can be the treatment plan for a patient with diabetes. When those lifestyle modifications are given a chance to work, if that can work, that's great. But if lab tests and blood sugar numbers show that that alone is not working, those things still need to be employed, but the addition of medications may be necessary as well. So again, for a type 1 diabetic, insulin will always be the mainstay in the treatment plan because their body does not make insulin. But for a type 2 diabetic, they may be able to use oral medications, they may need insulin or some combination of the two, along with the lifestyle modifications.
I'd like to cover medications at this point. It is essential that all healthcare providers in correctional settings have a strong mechanism in place for the control and inventory of medications. Medications should be available when needed and secure at all other times. Medication administration should be done by medical staff at all possible with appropriate documentation. If they cannot actually administer the medications themselves, then they can train non-medical staff, depending on what state you're in, to deliver those medications. A check with your local legal department as to who can actually administer medication. The correctional staff do play a critical role in the medication administration process because they really need to be present in order to maintain security and control of the medications, and also to conduct mouth checks and reduce the risk of cheating medications, because medications, as we all know, can be a really awful source of contraband in the facility and also be very life-threatening when it is used by individuals in either the wrong amount or used by a kid that is not his medication and may actually be contraindicated or not good for them. All refusals need to be documented and prescribers notified of such non-compliance. In order to control the cost of these medications, you really want to have a medication formulary. And a formulary is only a list of approved drugs that can be used by the prescriber without any additional oversight or management by another authority. Dental care is probably the most underserved need of these individuals, possibly behind behavioral health needs, because this population really has a lot of high dental health needs. Many have never been seen by the dentist since the screening that occurred prior to their entry to elementary school or preschool, and really have not received any regular visits to the dentist. Screening can be conducted by non-dental health care staff with a training that's conducted by the dentist. In other words, you could utilize a nurse to just do an initial screen for dental problems, but the actual examinations should always be done by a dentist with a treatment plan developed And these treatment plans really should have purposes of tooth restoration rather than just extraction, which sometimes is the case in older or more adult populations. Sick call requests really should also include requests for dental services as well as requests for medical services. When youth come into the facility with braces and other dental devices, it really can create a security risk if they're inappropriately used, whether kids pull out wires to cut, pass those to other individuals. So really a staffing needs to occur with those, with the orthodontist and possibly the facility dentist and all other parties that are concerned, which of course would include security, as to whether or not that dental treatment can be maintained, what was the history of the dental visits with the braces prior to being detained at the facility. All those things come into play when you're trying to make a decision as to whether to continue the dental orthodontist. Prophylaxis in the community really is required every 6 months. That is the community standard. A system of tracking should be developed, especially for youth that move in and out of the system, in order to really meet those timelines, because they may be in the facility when they get the first prophy and released and returned, and unless you have a really good tracking system, it will be difficult to know when they're due for their next cleaning. Of course, oral hygiene should be taught and practiced by the youth and encouraged when they are released as well. The last slide that we have, and hopefully we'll have lots of time for questions, is to really cover a lot of the medical unique situations that occur in correctional settings with the use of restraints and restrictions. Medical evaluation should always be made after the use of any type of restraint, whether it is a physical restraint or a mechanical restraint, and those assessments or those medical evaluations should really determine or make some type of assessment of that injury, and that assessment should be done by medical staff and should, if all possible, be done in a private area or way that that young person can really give the medical staff the history and an assessment of those injuries be made without the interference of the security staff. Any allegations of abuse that are reported from that encounter really need to be reported using the agency's mechanism, either for direct reporting or reporting up the chain of command, and certainly even if there is internal investigation required and involved in that process. When youth are in room restrictions, they really should have the same access to health care as youth are available in the general population. And they need to be seen at least daily by the medical staff when they do rounds when they're in room restrictions. Room restrictions can be used for medical purposes as well. For example, if there is a young person that you feel may have an infectious disease and you want an assessment done by medical prior to them being released to general population, or a child has flu or another infectious disease that they need medical isolation, then room restrictions can be used. But again, medical staff need to see those youth at least on a daily basis. And certainly in all cases, communication with security is essential in the provision of health care to these detained youth, and I can't emphasize that enough in being able to make certain that we are providing the best care for them in this secure environment.
I want to thank our two wonderful presenters for the wealth of information that they've shared with us today. At this point, we're going to continue to field as many of the questions asked by you all today and try to get responses to all of them, or at least as many as we possibly can. The first question we have is, what screening and assessment tools are you using or do you recommend that are inclusive of these common health conditions for diverse youth?
Again, I had mentioned rather briefly at the beginning the American Correctional Association and the National Commission on Correctional Health Care both published screening requirements and guidelines for individuals within juvenile detention centers, and I would recommend that you move forward and look at those because they're very thorough with regards to what assessments should be made. There are some changes that may be coming about with regards to the new PREA requirements with questions that should be asked that may not have been asked in the past with regards to sexual orientation, but those also are out there on the web and can serve as a resource for developing questions.
Thank you. And do you recommend segregated medical units in facilities? And if so, what conditions would warrant medical segregation?
I don't recommend a segregated medical, are you considering like a segregated housing unit? I really see no need for a segregated housing unit. We need to base the need for what we call medical isolation based on the medical need of the child. And I'm only talking with regards, I'm not dealing with the security aspect, I'm only dealing with the medical aspect with regards to the need for medical isolation. I think that room confinements in most cases are adequate to be able to control any spread of infectious disease. Now, if you have a pandemic or a mass epidemic in a facility, then you may have to move in that particular instance in segregating an entire unit. For example, they've all got flu. But that would be a short-term solution to that problem.
Excellent answer. You had mentioned PREA and sex abuse screening requirements. Are you using a specific screening tool to detect sexual abuse?
We have created our own assessment tool. I think most jurisdictions are doing the same. They're looking at their current screening tool and adding the PREA requirements to that. I believe everyone has either already updated their screening instruments, and that is how most people are addressing it. And even with the screening piece is only the initial part, because once you determine that a sexual assault has occurred, there's a whole cascade of requirements that are mandated by PREA that you have to have in place beyond just the screening instrument.
And what are your thoughts about youth with diabetes self-administering their insulin? And what guidelines, if you are in favor of that, would you recommend related to this practice?
So I think it's a very important practice that youth are well versed and familiar in administering insulin, if that be the case, in checking their blood sugar. And most diabetics learn that very quickly. So it is something that should be bolstered and supported. I understand the security restraints in our facility. For example, the youth will self-administer their medications as part of the education and self-management, but it's under supervised conditions. So obviously we're clear on how many needles are going into the room, and we have to make sure how many come out of the room, and then there's searches afterwards just to make sure that if there was any missing items that they were identified immediately. But self-management is very key, and that would include making sure kids knew how to self-administer insulin, how to check, do their finger stick sugar checks on their own.
And what options are available with those who tend to use their chronic illness as a tool for manipulation?
I would caution you to be very careful with the term manipulation because they do have a chronic medical condition. It is almost impossible to tell when there's a true medical complaint or a quote manipulation. So I think every medical complaint needs to be taken seriously. I do, however, know that there are certain individuals or certain youth that tend to complain quite a bit and really burn out the medical staff. So what I would suggest in those cases to set those individuals up with a standing appointment so that they don't have to put in a sick call requested. They know they're going to see the nurse every Tuesday morning, and that hopefully will cut down on some of the excessive complaints that may really be somatic or really a result of a mental health condition that's being transferred to a medical complaint.
To your point made in the portion on pregnant teens, does PREA also suggest and or require screening for intimate partner violence? It would be great if all youth were assessed for CSA, PV, sexual assault, sexual trafficking, sexual coercion, and reproductive coercion.
I can tell you what we're doing here. We're working on partnerships with one of the children's hospitals to actually have that in place where we can determine, well, at least question particularly the young girls with regards to sexual exploitation, and have a process in place to really treat them as victims, which is what they are, and try to prosecute those individuals that have been perpetrators.
What are your recommendations for caring for youth that consistently refuse treatment?
That's always a very difficult one. Coaxing, begging, I've used all of those, but what we've tried at our facility is to identify providers who may have a better relationship with the youth. There may be several providers. Well, we're fortunate to have a situation where we have multiple providers, so maybe someone has a better patient-provider relationship with a different provider. If not, and I know many facilities don't even just have the one provider, sometimes we will enlist the help of correctional staff. Maybe a youth has a good relationship with one of the direct care staff that they interact with that could help us. Sometimes we will have to use that in the best interest of their health. There may be mental health staff if we have psychologists or psychiatrists or social workers who have developed a strong relationship that we could use that relationship and use that person to try to encourage the patient to participate proactively in their care. And even I will call a parent or guardian and ask for the parent or guardian, explain to them the situation and why the care that we're trying to provide or the treatment that we're trying to use is so critical. And sometimes if we're fortunate to convince the parent or guardian, then the parent or guardian can now try to talk to the youth. Again, none of these are 100%, but these are all some of the things that we do try.
Absolutely. What are the recommended guidelines for fluoride treatments for youth?
Our water is fluoridated. Here, I think you have to check with each local dental association to see if there's fluoride in the water. If it is, then you don't need to do the additional supplements. Now, again, I'm not a dentist, but this is what has been my understanding. So I would just check with your local dentist or your dental association to see what those requirements are, whether or not you have fluoride already in your water supply.
And while we're talking about dental, who pays for these services when Medicaid is cut off when you enter a detention center in Virginia? Unless you're sent upstate to a facility, you kind of have to be very creative for payment of dental care. Typically, only emergencies are covered.
Well, I think, Dr. Ziki and myself, we have dentists that come on site to provide services. That's probably the easiest. To just pay a dentist to come for a set number of hours for routine dental care and hopefully have the arrangement that he or she can return to the facility for dental emergencies. We also have in place dental nursing protocols that they can attempt to address some minor emergencies such as a child with tooth pain with an instate until the dentist can see the young person.
And if there's no medical emergency, should dental treatment be offered? this person is at a smaller facility with only one nurse and one doctor that visits once a week. They have no dental provider in-house. And for example, a detainee has a chipped tooth with no pain or sign of infection. Should this fall on the parent after release, or is it expected for the facility to take care of that?
I prefer to have dental services on site because dental health is so critical to your physical health. I don't know if you recall in the news, it may have been several months ago, maybe even a year ago, where a young man died as a result of an untreated dental abscess. So I think it's critical to have some level of dental care in every detention center because that is a part of health care. How you do that, again, may be, you may need to be a little creative. The other source that you may want to consider is public health that may have some dental services that you may be able to create a memorandum of understanding with in order to see your young people, since they may be released back to that community, and then they can just pick those youth up as patients in public health.
Great. Now, ladies, with this next question, let's keep in mind that I'm a lawyer by trade, so I don't exactly understand some of this question, but I'll try and do my best. For youth on Seroquel with pre-diabetes, how often do they need to monitor the HBAIC? Is it okay to monitor every 6 months, or does it need to be done more often?
If anyone who is at high risk for diabetes, I think every 6 months. For someone who doesn't have signs of elevated sugars or previous A1C is normal, 6 months is a reasonable time frame to look for the effects, the potential effects of diabetes due to the medication. I don't think I've seen anyone do it like quarterly, because even well-controlled diabetics, they don't have to be screened with A1Cs for every 6 months. So for someone who doesn't even have diabetes at the last check, I think 6 months is very reasonable.
What time frames do you recommend for nurses and physicians to see youth who are confined to their rooms, such as hourly, every 4 hours, etc.?
It depends on the medical condition. For example, if it's just a routine room confinement and they don't have any medical complaints, they may have they don't have any medical complaints, then daily may be adequate. But if they're on medications 3 times a day, they'll need to be seen 3 times a day to get the medication. If they are very febrile or having a high fever or a very critical illness, then it may require every hour or less.
Great. And what, if any, specific protocols would you recommend for inventory control of medications? How often should an inventory be done?
I like the use of what we call blister packaging. It looks sort of like a bingo card with bubbles in it, and each pill is identified individually. And so it makes it easy to count. I like that method. And then certainly with each shift, you will want to count the medications, particularly controlled medications that may get out into the facility. And so, and also the use of a pharmacist as a consultant or as an employee is helpful in your medication management along with your nursing staff.
All right, just a few closing things. I wanted to thank everyone again for participating in today's webinar. I think we had a great series, and we thank you for being a part of it. I also wanted to call to your attention that next month begins a new 6-part series on evidence-based practice. Next month's webinar will feature 3 dynamic speakers who will share information and their experience with implementing trauma-informed care in their facilities. So be on the lookout for more information about that. We wanted to thank NTTAC and everyone for their help in actually facilitating this. If you could also take a few minutes just to complete the online evaluation, it'll be available to you at the conclusion of this webinar. Everything that we've done today is also archived on OJJDP's online university, so you can access it if you need to refer back to it. And for more information from anyone, we've provided contact information and some links for you. And again, thank you so much for participating with us, and please take a few moments to fill out the survey.